Hello and welcome to Health Talk. I'm your host, Angela Baracco-Eddy. With me tonight is Dr. Carl Speer. He is with Gastroenterology Associates of Pensacola. You can find him at the Endoscopy Center on Davis Highway. If you have any questions tonight, we will be talking specifically about colon cancer screening. Colon cancer and the screening methods for colon cancer. So we are live this evening. They'll have the phone number on the screen throughout the program, but I'll go ahead and give that to you as well. There's a new number, relatively new. We've had it for a few months now, but it's 850-972-2642. Again, that's 850-972-2642. If you have any questions or comments about colon cancer or colon cancer screening, that is our topic for this evening. We would love to hear from you. Get your question or comment on the air. If you're uncomfortable speaking on the air, we do have people who are answering the phone off the air, and they'd be happy to take your question and bring it to us during the program, and we can get your question answered, and you won't necessarily have to ask it on the air. Of course, we always like to have the interaction with you on the air, but if you want to just call in with your question, feel free to do that, and we will get that answered as well during tonight's program. Dr. Speer, as always, it's great to see you.
Thank you. Good to be here.
And we're talking tonight about colon cancer and colon cancer screening.
Yes.
Let's start kind of with even more of a basic question. Let's start with, what is gastroenterology to start with, and then we'll get more into colonoscopies and colon cancer.
Well, for our specialty gastroenterology, we cover the digestive system, which really includes 7 organs, including the esophagus, the stomach, the small intestine, the colon, the liver, the pancreas, the gallbladder. And so we deal with diseases to all these different parts of the body. Tonight we're talking about one of the most important, which is colon cancer, and how we prevent it and how we screen for it. But generally our specialty is quite broad and cover quite a few different disease processes.
So when we talk about colon cancer and colon cancer screenings, why is colon cancer so important that we screen for it on a regular basis?
Well, colon cancer is actually the 4th most common cause of cancer in the United States. And unfortunately, the 2nd leading cause of cancer death. So we're not doing a very good job at finding colon cancer early, or actually preventing colon cancer by various methods that we'll talk about tonight. So the fact that it's the 2nd leading cause of cancer death means we're not doing a good job of picking it up early at preventable stages. And that's where the colon cancer screening comes in. People do much better if we find colon cancer at a much earlier stage than a later stage, when it's spread to the adjacent lymph nodes, the liver, the lungs, or other places in the body where it tends to go if found too late. So the whole purpose of tonight's topic is to help find colon cancer at an earlier stage so that it can be treated much more effectively. If you diagnose a colon cancer at an early stage, the 5-year survival rate is about 90% or greater. If it's advanced, it's much less and much harder to treat once it's spread to other organs. So it really is important to find it early and treat it aggressively early. And if found early enough, sometimes just an endoscopic method of removing a mucosal cancer is all you need to have done. Sometimes surgery is needed if it's found too late, chemotherapy and possibly radiation therapy, depending upon where it's located. But ideally, if we can prevent it, that saves a tremendous number of lives. About 1 in 18 Americans will be affected by colon cancer. And so about 50 to 60,000 people die annually in the United States as a complication of colon cancer. So we really have a lot of work to do to try to prevent these very preventable deaths and complications from cancer.
And that's the key term, especially for this evening. It's preventable in most cases. The screening happens at an early age, not necessarily an early, but we'll get into that a little bit. Relatively early age, so now that I'm the age that I am, I think it's still really young. But it happens at an early stage, age 50, and so at that age you start the screenings, because typically colon cancer develops after the age of 50, correct?
Right, and we know most, not all colon cancers start actually as a polyp or a small growth in the colon, which is why we do screening colonoscopies. When we do a colonoscopy, we take out polyps, which prevents colon cancer later. So there's evidence that we've decreased colon cancer incidence about 30% over the last 10 years just by doing colon cancer screening methods. So we're going in the right direction. Unfortunately, only about 60% of the population who are eligible for colon cancer screening actually get screened. So the other 40% of the population who are eligible are at risk for colon cancer. So we need to identify those people and get them screened.
And not all cancers have a method to screen for. So
Correct.
When you have a particular cancer that you can screen for early and then prevent that cancer from developing or find it at a very early stage, as you said, the treatments are much easier, much more effective, hopefully can prevent the later stages.
Right, and particularly with the pancreas, we don't really have an effective method to screen for pancreatic cancer, but once diagnosed, it goes very quickly. So we really have an advantage in colon cancer in that we think the progression, or we know the progression from a polyp to a cancer, particularly if it's an adenomatous polyp, may take 10 to 15 years or possibly longer. So we have this lag time during which we have a chance to detect it, particularly if it's an adenomatous or precancerous polyp, to detect it and remove it before it has a chance to turn into cancer. But you've got to come in to have your colonoscopy to find these things so that we can prevent colon cancer.
Absolutely. So let's start talking about the screening. The most common screening, the one that most people know about, hear about the most often, is a screening colonoscopy.
Correct.
Let's talk about that. At what age is it recommended that people have their first one? And then let's talk about the procedure a little bit.
So the average age for the average person who has no family history, no other increased risks for colon cancer or fit into some of the polyp syndromes that are familial, the standard age for starting a colonoscopy is 50. And then if there are no polyps at the time of that colonoscopy, it's generally repeated every 10 years, generally to 75 or possibly 80, depending on what your life expectancy may be at that point. If we find polyps along the way, we take them out. Depending upon the pathology, the size of the polyps, and how many you have, we then determine at which point you need your next colonoscopy, but typically it's every 5 years after that. So for a normal colonoscopy, we'd do it again in 10 years. If you have multiple polyps, particularly if they're precancerous, we'd do it again in 5 years. So the colonoscopy is a test where we give you something to drink to get you all cleaned out. And for most people, anesthesia puts you to sleep, take a look around your colon, and then you wake back up afterwards. The whole procedure, the colonoscopy itself generally takes about 20 minutes, sometimes 30, depending on how many polyps you have. And you're generally with us about an hour and a half or so. You wake up afterwards, we let you recover from the procedure, and then you go home with whoever brought you to have your procedure. We don't let you drive home because you're sedated for the procedure. And you wake up pretty well refreshed, but still we suggest that you not do anything that day that's really cognitive. It's best not to go back to work. Because of the anesthesia that we use these days for the procedure, you're awake enough to stop and eat on the way home, which is very important for most people because you're usually hungry. And then you can pretty much have a normal evening, and then the next day go back to normal activity. So you really only need to take one day off of work to have this done. And most people do fine.
I've heard a lot of people that don't know as much about it, that they seem to be a little bit concerned, not as much with the procedure itself, but with the prep. So let's talk about the prep. The thing that you drink that cleans you out. Let's just kind of talk about that for a few minutes. And really, to put people's fears at rest, because I think people always imagine it worse than it is. One of the things that people tell me all the time is, it wasn't nearly as bad as I expected, and it was so worth it because they found a precancerous polyp, and now they know that that won't develop into colon cancer. So let's talk about the prep.
Well, it's obviously the worst part of the procedure. And there is a lot of false information out there about the prep, and people are really nervous about it. But we've really simplified it quite a bit over the last 5 or 6 years. And there are about 5 or 6 different preps that we use, and we tailor it to the patient depending upon their previous exposure to a prep that they had a problem with, if that's the case. Certain preps we don't use in people that have kidney problems, if they're on dialysis or prone to kidney insufficiency, and certain people who are maybe in mild congestive heart failure will taper the prep according to their medical issues. But for most folks, the prep consists of a preparation where essentially you drink a quart of the solution the day before, and if we cut it in half and you do a quart the night before and a quart the morning of the procedure, we get a very good preparation, and you don't have to drink, say, a gallon of the old prep that we used before we had these newer preps. We also use a magnesium citrate prep, which is those are the small 6-ounce to 12-ounce bottles that you get over the counter. And we do essentially a bottle and a half the night before and a bottle and a half the morning of the procedure. So we found if whatever we give you, if we cut it in half and you do it half and half, you're not drinking it consecutively, so you don't get quite as nauseated as some of the larger, older preps. And you get a good night's sleep, and we get a much better effect of the prep that you drink. And so for most folks, it's really not as bad as they anticipate. And for the patients that are afraid of the prep and do it, most of them are very pleasantly surprised that it wasn't nearly as cumbersome as they thought.
Which is always a good thing. We have had a call come in, so I want to get the caller on the air. Hello, and thank you for calling. Do you have a question or a comment for Dr. Speer?
Yes, I wanted to ask a question about polyps. I have had polyps removed, and what exactly happens where in other words, they got a report back and they said they were benign, but can you talk a little bit about the different types of polyps, and when did they become cancerous, and how's all that determined? I guess more than anything, I'm just concerned about what stage a polyp is in and that type of thing. How do you know, and how do you know if it's cancerous? And I'll hang up and listen. Thank you.
Thank you very much for your call.
Well, there are different types of polyps, and the ones that we worry about are the adenomatous polyps that are precancerous. And there are various grades of severity of these adenomatous polyps, from low-grade dysplasia to a villus adenoma to a tubular villus adenoma. And these are just grades of severity of the progression to colon cancer. So whenever we find a polyp, if feasible, we take it out at the time of colonoscopy. We'll remove it completely, if possible, and then we send it off to the lab for analysis. So for most folks, when we do a colonoscopy, we can kind of get an idea of how the polyp looks depending on the size and the appearance as to whether it's going to be a suspicious polyp or not. But we don't have the final report until usually 4 or 5 days after the procedure. So when we tell patients after the procedure how it went, we'll say, well, we found 5 polyps, but I think they're okay. That's subject to change depending on how the pathology comes back. And for the most part, we're right about the nature of the polyps. Sometimes we're surprised and have to go back and take another look earlier than we would have normally planned on. But we don't know for sure until we get the pathology back from the lab. And so we use that to then determine what we do next. If there are lots of large polyps, we may bring the patient back sooner than actually a year, particularly if there's one that's particularly suspicious, was large, we weren't sure we got it all out, we would go back in maybe in a month or so and take another look. If there are more than 3 adenomatous polyps, particularly if they're large, we would plan on doing the colonoscopy again in 3 years. If they're all fairly unremarkable, under a centimeter in size, and they're all adenomas with low-grade dysplasia, we would do it again in 5 years. So a lot depends on how big the polyps are, what the final pathology comes back as. So when we talk to our patients after the procedure, we can generally make a pretty good educated guess as to how the polyps are going to be. And I'll generally tell patients, well, I think we're good, we'll see in 5 years. If there are problems, I'll call you. And so if we get a surprise back, I'll call the patient and say, look, this is what we've got, this is what we're going to need to do. Our strategy changes now because of the final pathology, which was somewhat surprising.
Mm-hmm.
But sometimes we just don't know until we get the final path report back.
Sure.
But
go ahead.
But it is important to get the polyps completely removed. So sometimes if we're not quite sure, we'll go back even in a couple of weeks just to make sure that suspicious polyp is completely removed.
Absolutely. I want to talk about polyps in a little bit more detail, but it's time for us to take our first break. So stay with us. We'll be right back with more Health Talk.
Our weight. It's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
Has anyone ever said, you're the picture of health? You look healthy, you feel fine, but that may not be the full picture. Colorectal cancer is the second leading cancer killer of men and women over 50. It doesn't always cause symptoms, but it can be prevented. Screening can find precancerous polyps so they can be removed before they turn into cancer. Get screened. Make sure you are the picture of health.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Carl Speer. He is a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. You can find him at the Endoscopy Center in Pensacola on Davis Highway. Tonight's topic is colon cancer screening, and we're talking in quite a bit of detail about colon cancer screenings. So far we've been talking about colonoscopies. We will talk about that some more, but we'll also talk about some other screening methods later in the program. If you have any questions or comments that you'd like to have answered on the air, give us a call. The number will be on the screen throughout the program. The new local number is 850-972-2642. 850-972-2642. Give us a call. We would love to get you on the air. If you have a question and you don't necessarily want to ask it on the air, you're certainly welcome to call us. The ones who answer the phones will take your question and they will bring it to us throughout the program. So you can certainly have your question answered without being on the air. If you're a little bit shy, that's okay. We'll let that slide this time too. Tonight, again, we're talking about colon cancer and colon cancer screening. Before the break, we were talking a little bit about polyps. We had a great call come in asking about polyps and a little bit in more detail about that. I have a couple of questions for you, Dr. Speer, based on the polyps topic. I said I wanted to get into that in a little more detail. Mm-hmm. First, what causes polyps in the first place?
Well, we know about 5% of polyps are people who fall in these colon cancer polyp syndromes, and there's several out there that are actually genetically induced, hereditary, different types of inheritance over time. So a positive family history of one of these polyp to colon cancer syndromes is very important because these people we would screen at an earlier stage. So that encompasses about 5% of cancers, with a polyp turning into a cancer, generally at an accelerated rate, usually less than the 10 to 15 year time interval, maybe just several years. About 20 to 30% are hereditary, and we can identify different genetic factors that predispose one to both polyps and colon cancer. And then the rest, we just don't know. We think there's an environmental influence. Diet plays a role. Lifestyle, habits play a role with both polyps and colon cancer. If you're overweight, you're more likely to have polyps. If you smoke, you're more likely to have colon cancer develop over time. And various lifestyle factors play a role as well. People that exercise more frequently than others tend to have less of a chance of polyps and colon cancer, irrespective of their weight. So there are all sorts of different factors for the vast majority of polyps and colon cancer that we think play a role, maybe synergistically, to influence a polyp to turn into colon cancer. So really only 30 to 35% we know have a definite origin. The rest we're just not sure about.
We're not sure, which is why it's so important to have the screening done. We've had a call come in, so I want to get to the phone. Hello, and thank you for calling. Do you have a question or a comment for Dr. Speer?
Yes, I do. I'm a young guy, and I never had my colon cleansed, but I've heard that even a young person can get their colon cleansed just for healthy reasons, just so I can feel more fit. Is that true?
So we're talking about colon cleansing and things like colonic enemas, colonics. There is really no good scientific evidence that that makes a difference. On one hand, you'll have people that swear by this. Scientifically, it's kind of out there as one of these holistic approaches to medicine. You know, if you're having symptoms, constipation, diarrhea, abdominal pain, then, you know, this is a sign that you probably need to see a physician. For folks that feel better after colon cleansing, that's fine, have at it. But there's really no good evidence that it would say prevent polyps or prevent colon cancer over time.
Okay. Well, thank you so much.
You're welcome.
You're welcome. Thank you for calling. That's a good question. The over-the-counter things, and a lot of people are talking about, should we do this, should we do that, what are the best things? What in your practice do you recommend to people to have a healthy colon? Are there diet things, lifestyle things that people should be doing? Let's talk about that.
Yeah, there are quite a number of things you can do. We can start with the things that you shouldn't do, and certain foods that you should avoid, including foods that are high in fat. Red meat is typically a no-no in excess. So there are studies that show excessive red meat consumption results in increased cancers of the distal colon and rectum. So it's in the sigmoid colon and rectal cancers. So it's advised not to have more than 2 servings of red meat a week if possible. Alcohol is interesting as a risk factor for colon cancer, and there are different studies that show different findings. Generally, distilled spirits are thought to be more likely to lead to colon cancer. There are certain exceptions. Generally, most studies show that if you drink over 3 alcoholic beverages a day, it's not beneficial, and there are a whole host of medical problems that can develop, not only including liver disease, but also higher cardiovascular disease. The health profession study by Harvard did show 2 alcoholic beverages a day decrease the risk for heart attack and stroke. But once you get over 3 alcoholic beverages a day, most studies show that the benefits go away and you're at an increased risk for certain cancers. And with excess alcohol, esophageal cancer, gastric cancer, colon cancer, as well as pancreas and liver cancer. The exception to this is red wine, and there are several studies that show red wine may actually be beneficial in some cases. They're the polyphenols in red wine that in rats have been shown to reduce the risk for colon cancer in mice that have colon cancer cells implanted in their colon, and they don't develop into bigger cancers or more metastatic disease over time in rats fed red wine. And there's some studies in humans that already have colon cancer, people that have actually advanced colon cancer, if they have 1 or 2 glasses of red wine a day, the progression of their colon cancer is less, and they actually live longer. So you have to take some of these studies with a grain of salt, but in general, alcohol over 3 beverages a day is not good for most cancers and your risk for heart disease. Somewhere between 1 and 2 glasses a day, particularly of red wine, could be preventive for colon cancer, possibly polyps, and some other cancers as well.
I think that that's an important thing. One of the other things that you mentioned with the caller, if you're having symptoms, if there's a concern, and that's why you're doing one of these cleanses or something like that, before you do that, you should probably contact a physician. What are some of those symptoms that someone might have that might say, yeah, you probably need to see a doctor?
Right, and that's a good point. And if you're having any problems, so any changes in your bowel habits, especially if you're over the age of 50, whether it's constipation, diarrhea, or just something different, if you haven't already been screened, particularly if you're a bit older, you should probably see one of us and have a colonoscopy. Anytime you see blood in your stools, if it's other than just obvious hemorrhoids that are bleeding, you should have a colonoscopy. If it's not blood, if it's darker stool, which may be an indication that the bleeding's coming from higher up in the GI tract, particularly if it's dark and tarry or if it's maroon blood in your stool, and sometimes you can't tell that it's blood, it's probably best to see one of us and we can test your stool for blood. If it's positive, then decide which way we start, whether we start with an upper endoscopy or a colonoscopy. We also have a capsule camera that you swallow that takes pictures of your small intestine, so we can cover all aspects of your GI tract, either endoscopically or remotely, to find sources of bleeding. Loss of weight is important, abdominal pain, particularly if it's associated with bowel movements, but anytime you're having vague abdominal pain, it's probably a good idea to see one of us. And then other symptoms with your upper GI tract, particularly for esophageal and gastric cancer, if you're having trouble swallowing, if you're getting full fast, if you're vomiting unexpectedly, if your abdominal wall or if your abdominal cavity is swelling and you don't have any obvious idea why that's happening, i.e. you're not gaining weight, it's not obvious fat, that would be an indication to see one of us.
So some important things if you see those symptoms that you need to see someone, but the important thing about the screening is the screening happens at a certain age when there are no symptoms.
Right.
That's important.
Right. To be classified as a screen, you're not having any symptoms at all. You're just coming in because of your age or your family history. Now with the family history, if you've got a family history of colon cancer, particularly if it's a first-degree relative, we would want to see you sooner, and we generally start at 40, or if you have a family member who had a colon cancer at an early age, we would start 10 years before that person was diagnosed with colon cancer, 10 years before the age at which that person was diagnosed with colon cancer. And there are various different hereditary colon cancer syndromes, and if you're identified as having one of those, we would do your colonoscopy significantly sooner.
We have a call coming in. I want to make sure that we get to the phone. Hello, and thank you for calling. Do you have a question or a comment for Dr. Speer?
Yes, I do. I'm going to ask the question, then I'm going to hang up and listen to you on air.
Okay.
My question is, I'm 73. My last colonoscopy was in 2005 or 6. Mm-hmm. Do I need to have another one, or do I need to have one of those things where you check your stool for blood and all that? I'm going to hang up and listen to you.
Thank you for your call. There might be some different answers based on what that previous colonoscopy showed?
Well, I didn't have a chance to ask that, and particularly if he had polyps at the time of
we'll
his
give you
last
two
colonoscopy.
answers. There you go.
Right. But I think that actually it's going to be one answer. The answer is yes, you probably should. At 76, now, particularly if you had polyps with your last colonoscopy, but it's been over 10 years since your last colonoscopy. If you're otherwise healthy, 76, I would have another colonoscopy. The U.S. Preventive Health Services Task Force actually recommends stopping at 75. However, a lot of us are living a lot older, a lot longer, and living longer lives. And so the risk for colon cancer, you remember, goes up as we get older. So if you're otherwise healthy and don't have any other comorbid conditions that might affect your lifespan, it would be reasonable to have another colonoscopy, particularly if it's been 12 years after your last colonoscopy, and particularly if you've had polyps somewhere along the way. So the answer is yes.
Yes,
I would have
it would probably be worth it. But he brings up another point, something else that we wanted to discuss during the program. He said, is there something you can just test the stool or something like that? Let's talk about some other it's time for us to take a break. When we come back, we're going to talk about some other screening methods that are out there, the effectiveness of those and such things like that. So stay with us. We'll have a lot more when we come back with more Health Talk.
It's impossible to replace anybody that you loved. She was my great role model, my Grandma Keaton. It was pretty much of a shock for us when she got colon cancer. None of us were prepared for that. Here's the deal, and this is the bottom line here. Colorectal cancer is the second leading cancer killer of men and women over the age of 50. And you know what? This is one that you can prevent. Just get screened, okay? I know how precious life is right now. We can all do this. You can do it, I can do it. If I can do it, you can do it, okay? How's that for a deal?
Our weight. It's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Carl Speer. He is a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. Tonight's topic is colon cancer screening. We've been talking about colon cancer, the different screening methods. We've been talking specifically so far about colonoscopies. I said before the break we were going to come back and talk about some of the other screening methods. One of the callers that we had asked about stool testing and seeing, kind of what the results are of that and then where to go from there. Dr. Speer, let's talk a little bit about that.
Okay. There are several ways to screen both your stool and your blood to see if patients are at any increased risk for having colon cancer. The bottom line is if any of these come back positive, you do need to have a colonoscopy. But there are several stool tests. The earliest, the one that's been out the longest, is called a stool hemocult or stool guaiac test, which essentially just tests the stool for blood. Assuming that an advanced polyp or an early colon cancer is going to release some blood into your GI tract, even if you don't see it, you're going to pick it up on the stool testing, which is quite reasonable. So the one that's the oldest is the stool hemocult. You generally provide 3 separate stool specimens once a year for testing, with a sensitivity of about 40% or so, meaning you're still going to miss quite a number of cancers. The one that has come out second is called the FIT, F-I-T, or fecal immunochemical test, which is a little bit more specific for blood. It's an antibody to hemoglobin, with a sensitivity of about 62% or so. So a significant advancement over the stool guaiac. And then over the last probably 4 years, a more sensitive test called the Cologuard. So this test for not only for blood, but some different genetic markers, methylation of some of the colon cancer genes that are thought responsible for colon cancer, with a sensitivity now of about 92%. And so we've come a long way for those that choose just to have their stool tested. There is a blood test with a sensitivity of about 60%. It's called the EpiPro-Colon. That is, so it's, the sensitivity is somewhere between the stool guaiac and the FIT test, which can be done in folks that don't want to have to actually submit a stool specimen. But at this point in time, the Cologuard is actually the most sensitive. Now, statistically, about 13 or 14% of the Cologuards are falsely positive. And of all the Cologuard positive people that have been referred to me, I have to admit we haven't found any colon cancers yet. We generally find some smaller, possibly larger polyps. So it is a fairly good screen in the sense that it brings awareness to the patient that they really need to have a colonoscopy. And then generally we'll find some polyps that we take out, which could over time turn into colon cancer. So there are different screening mechanisms for those that are somewhat faint of heart and don't want to necessarily have a colonoscopy. But the bottom line is if any of them are positive, you need to have a colonoscopy to find out why they're positive.
Absolutely. I know that we've had a couple of calls come in. I'm sorry, I think that I've lost you a few times. We think that I've got another one coming in, so I'm going to try and get you right on the air without having to put you on hold. So I hope that I have you. Hello, and thank you for calling. Do you have a question or a comment for Dr. Speer?
Yes, I do.
Go ahead.
When I eat certain things, my stomach burns just 15, 20 minutes later, and I was told that when your stomach does that it's probably you have a ulcer or something like that down in my stomach. Is there such a thing as that going on? Just like when I drink my V8 juice, tomato V8 juice, things like that burn, makes my stomach burn. I'm calling it burn because I don't know another word to use.
Right.
Right.
Well, you are right. There could be some pathology going on. It could be an ulcer. It may just be, is the burning mostly in your chest or in your abdomen?
No, it's in my abdomen.
Yeah.
Well, really it's just, yes, where your ribs meet, that far down, about where your ribs meet.
Okay.
That little place there.
Yep.
That's where it burns.
I would see one of us if I were you. We would probably want to take a look in your stomach. The upper endoscopy is actually much easier than the colonoscopy. There's no prep. It takes about 3 minutes to do. We do sedate you for it, just to make sure that there's nothing like an ulcer that you mentioned is going on. One thing you may want to do is, if you haven't already, start one of the over-the-counter proton pump inhibitors like Prilosec or Nexium. It's esomeprazole or omeprazole of the generics, and just take it once a day until you get a chance to see one of us. And then you can generally get to see us in the office fairly quickly, and we'll be glad to take a look and make sure. But you're absolutely right. You do need to be concerned that there may be something more sinister going on, and we probably need to take a look in your stomach.
My medical doctor gave me a prescription for Carafate.
Okay. I would do that
and,
too.
I didn't know if that was for it or not. And
yes.
I'm just concerned that it might be something else going on.
It could be. In all likelihood, it's probably benign, but it could be an early ulcer. The Carafate should help too, but I'd probably add the over-the-counter omeprazole or esomeprazole or pantoprazole once a day in addition to the Carafate.
Okay.
Until you.
I knew it didn't have anything to do with what you were discussing.
Oh, that's okay.
I needed to.
Sure.
Yeah.
Sure. Yeah, you're obviously concerned about it, so I think I would follow through with that and would be happy to see you.
Thank you very much.
You're welcome.
Wonderful. Thank you so much for your call. We appreciate it.
Thank you.
It's a call that's related to gastroenterology. So
Absolutely.
at least it wasn't necessarily a specific topic, but it's related. So we appreciate you calling.
That
Thank
counts.
you so much. One of the things that kind of, well, and I want to get back to screenings, but I want to just kind of jump in for a minute. We had someone ask a question off the air that they brought to us, and it kind of goes along with her saying, you know, I need to get in and see you, or I want to come in and see you. Do I need to come in and see you? This question was, does insurance pay for the screening colonoscopy? And if so, how do you go about getting a referral? Do you have to get a referral? What's the process?
Right. Well, so the answer is most insurance companies do cover screening colonoscopy because they realize that if we prevent colon cancer, their costs are less. So they're really interested in the health of their patients. So they're on board with the colon cancer screening. So the vast majority of insurances cover screening colonoscopy. We get into a little problem sometimes when we do find polyps and take them out. We want to bring you back sooner. Your insurance company wants to leave you at the 10-year interval. But they will almost always pay for your initial screening colonoscopy. What determines referrals is typically your insurance company. And for most, unless you're in one of the HMOs, you can schedule an appointment directly with us. You don't necessarily need a referral or have to go through your primary care physician. If you call any of our offices or the endoscopy center and are not sure whether you need a referral or not, we can check and we can tell you whether you need a referral or not. But it's quite possible to just call us and schedule an appointment to discuss a colonoscopy. We generally like to speak with you first, have an office visit, go over your medical history, do you have any allergies, talk about the anesthesia, and give you an idea of what to expect. Sometimes we have to stop some of the medications that you're on, particularly if you're on blood thinners, several days before the procedure, just in case we find a lot of polyps and take them out so you don't have any bleeding after the procedure. But in general, you can just call us and schedule an office visit, and we can tell you whether a referral is needed. If you need a referral, we will then contact your primary care physician and get the referral for you. So you generally don't need to really do anything other than call us, and we basically take care of the rest.
Which is fantastic. And a lot of primary care physicians are getting better about, once you go in for your physical after you've reached the age of 50, to recommend that you call and schedule a screening colonoscopy. It's just like girl doctors do it all the time. For when women go in for their annual physicals or their annual pap smears, you schedule your mammogram. It's one of those things. It's the screening to try and catch the cancer early, so you can, if you do see something, you can treat it. It can be a more effective treatment. It's not quite so severe.
Right. And then earlier we were talking about things you could do and shouldn't do to help prevent colon cancer. So we talked about the things that you shouldn't do. The things that you should do are actually quite as important. Number one is exercise. And if you exercise moderately several times a week, your risk for colon cancer is reduced by half, which is pretty incredible, even without losing weight, which is encouraging. If you're overweight, your risk is increased. And people that have the central obesity, meaning you're shaped more like an apple than a pear, if you will, have a higher risk for colon cancer, again, irregardless of their weight. If you smoke, the combination of smoking and being overweight is synergistically accentuated. And if you smoke and drink more than 3 alcoholic beverages a day, your risk factors for colon cancer are significantly increased. And then there's we talked about the foods that you should avoid, but there are certain foods that you should probably add to your diet. And so, as we know, the Department of Agriculture suggested 5 servings of fruits and vegetables a day, just for general health reasons, which also helps protect you against colon cancer. The vegetables every day actually have a significantly more advantageous influence on reducing the risk for colon cancer, and fruit does too, but the vegetable increase in your diet helps. We talked about exercise, decreasing the fat content and red meat content of your diet. And then Other things like coffee, interestingly, has been proven to help prevent colon cancer over time. It doesn't necessarily have to be caffeinated. Even decaffeinated coffee seems to help. So it's clearly not the caffeine in the coffee that's protective, but 3 to 4 or more cups of coffee a day tend to be beneficial for most people. If you get to the point where the excessive coffee is causing problems, palpitations, other digestive system problems, then you should probably cut back. But most of the studies actually show 4 cups of coffee or possibly more to be more beneficial. Herbal tea has been shown to be beneficial. And actually for the herbal tea, it's 1 or 2 cups a day to be beneficial. And interestingly, the coffee helps prevent more proximal or right colon cancer, and the herbal tea helps to prevent more left-sided or distal colon cancer. So it's a sort of an interesting association. And then there's certain medications that actually are helpful. Aspirin has been looked at over a number of years, and we've gone back and forth about the benefits versus the risks of aspirin. But in general, aspirin helps prevent both polyps and colon cancer. So there's a recent study that just shows a baby aspirin a day after about 10 years reduces colon cancer about 25%. But clearly the more aspirin you take, the better. But it generally takes about 10 years to be effective, 6 to 10 years. For polyps, a lower dose of aspirin, like typically the 81 milligram a day for 3 years, actually helps prevent polyps. So if you're helping prevent polyps, you're also helping to prevent against colon cancer. Other medications, calcium, selenium, folate, vitamin B6 have been shown to be helpful. So if you are a woman who may be close to menopause, supplemental calcium would probably be a good idea, not only for strong bones, but also to help prevent colon cancer. And we generally aim for about 1,200 milligrams of elemental calcium a day. And you can pick that up with Tums with calcium. So if you tend to have some heartburn and indigestion, like our earlier caller, or maybe the epigastric discomfort, Tums with calcium would help protect your GI tract and strong bones, as well as possibly help prevent colon cancer over time.
Some great things that we're hearing, some good tips and some things you can do to make some changes to stay healthy longer. It is time for us to take our last break of the evening. If you have a question or a comment, please give us a call. We'll be right back with more Health Talk.
Our weight, it's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
El cine nos entretiene, pero esto no es la vida real. Lo que sí es real es que el cáncer colorectal es la segunda causa de muerte por cáncer entre hombres y mujeres. Los pólipos que lo causan pueden detectarse y eliminarse antes de que se convierten en cáncer. Pero tú lo puedes prevenir. Hágase un examen para detectar el cáncer colorectal. Yo lo hice. Podría salvar su vida.
Si usted es mayor de 50 años, hágase el examen de detección.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Carl Speer. He is a board-certified gastroenterologist with the Gastroenterology Associates of Pensacola. Tonight's topic is colon cancer screening. We've been talking about colon cancer. We've been talking about colonoscopies. I want to talk a little bit more about some of the additional screening methods. And I know, Dr. Speer, you mentioned earlier the only real problem with some of these other screening methods is if you do find something with one of these other screening methods, you still have to have basically a colonoscopy to remove polyps or to do biopsies or things like that. So knowing that, going in, What are some of the other available screening methods that are out there?
There are some radiological screening methods, X-ray, if you will. The oldest is the barium enema, which is installation of contrast barium into the colon, and you change positions. You have a catheter inserted in your rectum. The barium is instilled in and travels up your colon, and then they take X-rays of a distended colon, which is fine for big things like a big colon cancer or even a large polyp. The radiologists are pretty good at reading these. Again, if you see something suspicious, you need a colonoscopy. And then over the last probably 15 years, the CT colography, which is essentially a fancy CAT scan of your colon. And so this is a lot more sensitive than the old barium enema. It's good for detecting large polyps and early colon cancer, generally not for small polyps, with the thought that, well, small polyps aren't really that important, so we don't really need to be worried too much about them. But a lot depends on how often you do this. If you have one and decide that that's sufficient, which is not the right answer, you are at risk for developing colon cancer because they're going to miss the smaller polyps, which over time can develop into a big polyp and a colon cancer. And in fact, the radiologists generally don't even mention a polyp that's under 6 millimeters, which is still a pretty sizable polyp that we would definitely want to take out if we were doing your colonoscopy. So these are the two X-ray methods that are possible. There is in development, there's a capsule for the colon. Now, we use the small bowel capsule, which works very nicely, and we use it quite a lot in our practice for people that have bleeding from the small intestine. The problem with the colon capsule is that your colon is a lot larger, and the capsule you still have to swallow, so it can only be up to a certain size, and it tends to rotate once it's in your colon. And so they've tried to correct these flaws by having a lens on both sides of the capsule, so you essentially see the colon coming and going. You still have to take a prep for this, and the problem with the capsule is if you get to a part of the colon where there's an excessive amount of stool, you're not going to be able to see that well. Whereas if we were doing a colonoscopy, we would just simply wash that area off so that we could see better. When we do a colonoscopy, we actually spend a fair amount of time cleaning the colon a little bit further. Most of our patients do fine, but with the colonoscope you have the ability to remove any stool that may inhibit part of the colon from being visualized. And if we don't see an area well, we generally change the patient's position so that we can see that area well. You don't have that option with the capsule because it sees what it sees, and if there's more stool than is acceptable, you just don't have the ability to see that part of the colon real well. So all of these other screening methods have flaws. They're a lot simpler, other than the barium enema is somewhat painful. So for the folks that don't want to have a colonoscopy, this is certainly an alternative, but you need to do them frequently. You need to do, if you do the virtual colonoscopy every 5 years, is the recommended frequency. You can't just do it once and stop.
And I know that one of the concerns with people who are doing colonoscopies, and I know that we have a call holding, so don't go anywhere. We'll get to you in just a minute. But I just want to mention, one of the things that people are concerned about is having to do the prep. But even with these other things,
there's still a prep.
You still have to do a prep.
Yes.
So if you have to do a prep for these other procedures, and then you see something, and you still have to have a colonoscopy, then you have to do a second prep for your colonoscopy for them to then remove the polyps or to actually observe it in more detail.
It's easier just to do the colonoscopy.
Do the colonoscopy, yeah. Yes. That's my 2 cents. Do the colonoscopy. We have a call that's been holding, so I want to get to the caller. Hello, and thank you for holding. Do you have a question or a comment for Dr. Speer?
Oh, I do have a question. I was wondering if he had any suggestions for irritable bowel syndrome.
Mm-hmm. We do. What sort of symptoms do you have with your irritable bowel syndrome? What bothers you the most?
Constipation, bloating.
Okay. definitely we can talk about that
Definitely
for a minute.
very common. So we do have lots of different medications that we use for people with irritable bowel syndrome or IBS, and in your case it would be IBS-C or IBS with constipation predominant symptoms. The main object is to get your bowels moving more frequently, particularly if you're uncomfortable with not having a bowel movement every so often. So there are medications we can put you on to improve that. There are some medications that we put you on just for the discomfort, for the gas and the bloating. One of the other things when you see us, we'll also think about other options, particularly if you're uncomfortable, have distension, bloating. We just want to make sure that you don't have other things that may not actually be irritable bowel syndrome, because remember, with irritable bowel, there's no one test you can do to prove that it's irritable bowel. We usually like to rule out the usual suspects, if you will, and then if you don't have any of those by chance, it's irritable bowel. But we will, for the gas and the bloating, we'll test you for things like lactose intolerance, probably celiac disease. We always think about the possibility of food allergies, intestinal overgrowth of your small bowel or colon, which we can correct with probiotics. And so there are lots of different things we can do to try to make you feel more comfortable. At the same time, try to get your bowels moving more frequently. So we do have quite a number of things we can do to hopefully get you feeling better.
So I hope that answered your question. Absolutely. If you haven't seen one of the gastroenterologists, it's probably a good idea to do so, because it sounds like there are several options to help you feel better.
Right.
Thank you.
Thank you. Thank you very much for the call. We just have a couple of minutes left, but I want to talk again about the importance of colon cancer screening. We talked about the magic age 50, for most people, unless you have some of the risk factors. Tell us what some of those risk factors are. Different races, different ages, family history, things like that. We got about a minute and a half.
Oh, so quickly. Anybody in your family with colon cancer, particularly if they're a first-degree relative, is a risk factor, and you should start screening 10 years before they were diagnosed with their colon cancer. African Americans have a higher risk for colon cancer at an earlier age and generally are detected at a later stage. So we clearly have more work to do with that population. And there's a call for screening African Americans at 45, not waiting till 50. Hispanics have the same risks. So they have more frequent earlier colon cancer. They have cancer at an earlier stage. So they probably should be screened at 45. People who are obese actually have a high risk for colon cancer at an earlier age. And so this is not approved, unfortunately, by insurance companies, but there's some societies that suggest screening at 45 for obese people with a BMI of over 30.
Having said all of that, I'm sorry to cut you off, but it's time for us to go. Thank you so much for joining us. We appreciate you very much, and we look forward to seeing you next time when we come back with more Health Talk.